Welcome everyone to the weekly Neurology Deep Dive, produced by Amara Gavanini. Today we're doing a deep dive into a really challenging condition, progressive encephalomyelitis with rigidity and myoclonus, specifically the type associated with glycine receptor antibodies.
That's right. It's often sort of lumped in with stiff person spectrum disorders, but as we'll discuss, it has some very distinct features.
Features that are, frankly, quite explosive clinically, things that demand pretty immediate recognition from clinicians on the ground.
Absolutely. So our mission today is to really synthesize the key findings from the key paper on this, looking at the clinical picture, the outcomes, and crucially, the prognostic factors.
We're pulling out the practical knowledge from the study, progressive encephalomyelitis with rigidity and myoclonus with glycine receptor antibodies. Information you can hopefully use in your practice.
Information that might really impact how you triage, work up, and treat these patients, potentially starting, this week.
Okay, before we get into the weeds, we have to state our mandatory disclaimer. This deep dive is purely for educational purposes.
Yes, there's no commercial goal here. It's just a summary of the research.
And we strongly, strongly recommend you read the full paper yourselves for all the nuances and complete context. Now, for those of you short on time, maybe just joining us for a few minutes, here's the immediate practical summary, what you absolutely need to know. First, this specific autoimmune disorder, and let's call it GlyR-PREM2. For brevity, it's distinct from other conditions. It's very rapid, very progressive, and often very severe.
Second point, the demographics. They're almost a mirror image of classical stiff person syndrome. It hits men much more often, about 88% in this cohort.
And the age is different too, right? Median age around 58.
Exactly, 58 years median age. Older than you might typically think for stiff person spectrum disorders.
Third key takeaway. The presentation is fast. Often you're seeing severe brainstem symptoms, things like difficulty swallowing, trismus within just 2 weeks of onset.
Which is incredibly quick. And finally, treatment. Immunotherapy works. That's the good news. About 70% of patients who survived had a good functional outcome long-term.
But
There is. The two big independent predictors of a poor outcome, defined as a modified Rankin scale score of 3 or greater, were older age and needing intensive care unit admission.
Okay, that's the snapshot. Let's unpack this properly now. The study itself, it looked at 41 patients.
Yes, 41 patients. It was a mix 22 from a database and 19 pulled from the literature. And they all had at least 12 months of follow-up, unless, sadly, they died before that point.
So why is it so important, clinically speaking, to pull this GlyR-PREM out from the broader stiff person spectrum disorder category? Why make that distinction?
Because the differences are really quite dramatic. We're not talking subtle shifts here. The disease trajectory, the risk profile, it's fundamentally different.
If your mental model is based purely on the classic glutamic acid decarboxylase antibody stiff person picture,
You could easily miss the diagnostic window for GlyR-PREM. The speed alone requires a different mindset.
let's talk about that age difference again. You said 58 years median onset for GlyR-PREM.
That's right, 58 years, with an interquartile range of 43 to 66. Now compare that to previous series of PRM, before glycine receptor antibodies were routinely checked. Those reported a median age of 46, so significantly younger.
And the sex difference is even more striking.
It really is. The classical stiff person syndrome usually see more women, maybe around 60% female.
But in this GlyR-PRM group,
About 88% were male. It's a massive reversal.
Yeah.
So the takeaway for the listener is, if you see rigidity, myoclonus, plus brainstem symptoms in a patient over 50, especially if they're male,
GlyR-PRM needs to be very high on your differential list, maybe even ahead of classic stiff person syndrome in that scenario.
precisely. That strong difference must point towards a different underlying immune process, wouldn't you think?
It certainly suggests it, and that seems borne out by the data on associated systemic autoimmunity too.
Absolutely. Things like type 1 diabetes, other autoimmune conditions, they're relatively common in classical stiff person syndrome. Maybe up to about 35% of cases have something.
But in this GlyR-PRM cohort,
Much rarer. Only 3 patients out of the 41, so about 7%, had a known systemic autoimmune disease.
so while it's clearly autoimmune, it seems less tied to that generalized systemic autoimmune background.
That appears to be the case. However, that doesn't mean we ignore other potential underlying conditions. This study did find some important associations.
Like preceding infections.
Yes, about 24%, so nearly a quarter, had some kind of infectious process just before onset. That included things like varicella zoster, but also COVID-19.
And crucially, the paraneoplastic link.
Very important. About 22% had underlying systemic tumors. Things like thymoma, Hodgkin lymphoma were reported.
Which confirms this can be a paraneoplastic syndrome.
It absolutely necessitates a thorough malignancy workup in every single patient diagnosed with GlyR PREM. You have to look.
Okay, let's shift to the clinical course itself. This is where, as you said, it gets really interesting and, frankly, quite alarming. The speed, the severity.
The word I used before was explosive, and I think it fits. That median time from the very first symptom to needing hospital admission was just 2 weeks.
2 weeks. That's incredibly fast for something in this spectrum.
It really is. This isn't the slow, insidious progression we sometimes associate with, say, glutamic acid decarboxylase antibody stiff person disorder. And the symptoms reflect that speed. Brainstem involvement is very common very early.
You mentioned about 56% presented with brainstem issues, mainly bulbar problems. What are the key red flags neurologists should look for in the emergency department or on admission?
The top 3 symptoms were dysphagia, difficulty swallowing, seen in about 54%, then diplopia, double vision, in about 41%, and trismus, or lockjaw, in about 27%.
That combination of rigidity and trismus, that immediately makes you think about tetanus, doesn't it?
It does, and it really highlights the potential severity right off the bat. You need a very high index of suspicion because this escalates quickly. About half the patients, 51%, needed an intensive care unit admission.
Half the patients ending up in intensive care.
Yes, and it could be incredibly rapid. The paper mentions 4 patients who developed such fast respiratory distress they needed intubation on the very day they were admitted. These are true neurological emergencies.
Given this kind of dramatic, often brainstem-focused presentation, what does that mean for the classic triad we learn about: stiffness, muscle spasms, myoclonus? How reliable is that triad here?
Well, that's a really critical point. Relying solely on that classic triad can be misleading with GlyR PERM.
How so?
Only about 61% of the patients actually presented with the full triad at admission. So a significant minority didn't have all 3 components initially.
And even more importantly,
Even more critically, about 12% of the patients never developed muscle stiffness at any point during their illness course.
12% never had stiffness at all.
Correct. Which means the absence of stiffness absolutely should not rule out GlyR PERM if you have the other features, especially rigidity, myoclonus, and those prominent brainstem signs.
That is a huge clinical pearl. Don't wait for stiffness if the rest of the picture fits. And we shouldn't overlook some of the more unusual symptoms reported either, like the sensory ones.
Right. About a third of patients, roughly 34%, reported pruritus or dysesthesias around the time of admission, often described as itching, but not really following a clear nerve pattern, a non-dermatomal distribution.
Which might relate to glycine receptors in the spinal cord pathways for itch and pain.
That's the thinking, yes.
Yes.
And suggests the antibodies are hitting targets beyond just the motor pathways.
And even more unusual were the smell and taste symptoms.
Yes, quite striking. 2 patients, which is about 5% of the cohort, presented with cacosmia, perceiving unpleasant smells, or dysgeusia, where things taste wrong, like food tasting rotten.
Which suggests the antibodies might even be affecting areas like the olfactory bulb or other sensory nuclei in the brain.
It certainly points to a more widespread central nervous system involvement than just the brainstem and spinal cord motor pathways.
Okay, so we have this picture of a rapid, severe illness, often needing intensive care, sometimes with unusual features, and not always presenting with classic stiffness. Let's turn to management. Given the severity, what's the response to treatment and what's the longer-term outlook?
The encouraging part is that immunotherapy is definitely the mainstay, and it is effective. All patients in this cohort received some form of acute immunotherapy.
Usually high-dose steroids, IVIG, or plasma exchange.
Yes, those were the primary first-line treatments. And then a significant portion, about 39%, needed second-line therapy as well. That was typically rituximab or cyclophosphamide.
And did they respond relatively quickly? You mentioned the high severity at nadir.
They did show improvement. The median modified Rankin scale score measuring disability was 5 at its worst point, which is severe disability, often bedbound.
But by the time of hospital discharge?
The median modified Rankin scale score had improved to 3. That's still moderate disability, often needing help with daily activities, but it's a significant improvement from a score of 5.
And does that improvement continue after discharge? What about long-term function?
For many, yes. They followed the surviving patients for a median of 24 months. Among the 33 survivors with follow-up data, about 70% achieved what's considered a good functional status.
Defined as a modified Rankin scale score less than 3.
Correct. So scores of 0, 1, or 2, meaning anything from no symptoms to slight disability, but able to function independently. Achieving that in 70% after such a severe initial illness is actually quite a positive outcome.
It is, but that initial severity takes its toll. There's significant mortality associated with this.
Unfortunately, yes. The mortality rate was high. About 27% of the total cohort died. And drilling down, about 20% died specifically due to complications of the GlyR PREM itself.
And you mentioned age being a factor there earlier.
A major factor. When they compared those who died versus those who survived, the median age of the patients who died was 70 years.
Compared to
A median age of 54 years for the survivors. That's a big difference and clearly points to age as a significant risk factor for mortality.
For the patients who do survive the initial illness, what about relapses? Is this typically a monophasic illness, or do people have recurrences?
Relapses can definitely happen. In the group who survived longer than 6 months, about 28% experienced at least one relapse. There were 12 relapses in 10 patients overall.
And when do those tend to occur?
The median time to the first relapse was 16 months after the initial onset, so often more than a year later.
But the key point for managing these relapses.
The really important clinical finding was that all the reported relapses responded well to further immunotherapy. This suggests that if patients do relapse, hitting them again with treatment is effective and maybe implies a role for longer-term maintenance therapy in some cases.
Okay, let's nail down those prognostic factors. This is critical for counseling patients and families and for guiding management intensity. The multivariate analysis found 2 key independent risk factors for a poor outcome, right? Defined as modified Rankin scale 3 or worse.
That's correct. 2 factors emerged as statistically significant independent predictors.
First one was age.
Yes, the patient's age at onset. The hazard ratio was 1.06. So for each year older a patient was, their risk of a poor outcome increased slightly but significantly.
And the second, much larger factor.
Admission to the intensive care unit. The hazard ratio here was 5.26.
5.26, that's a huge predictor.
It's massive. It tells you that needing intensive care, likely due to respiratory compromise, severe autonomic dysfunction, or profound brainstem failure early on, is incredibly predictive of long-term disability or death.
Much more so than age alone, it seems.
Over 5 times more predictive, according to this analysis. It really suggests that the sheer intensity and neurological damage occurring in that initial explosive phase is what fundamentally dictates the long-term prognosis, perhaps more than just the duration of illness.
Which brings us back to the need for rapid recognition and aggressive early treatment, especially in those who look like they might be heading towards needing intensive care.
Absolutely. The initial triage and treatment decisions seem paramount.
Okay, let's try to summarize the absolute key points again for the practicing neurologist listening.
Sure. First, remember glycine receptor antibody-mediated PRM is a distinct clinical entity. It's rapid, it's severe, and it can mimic things like tetanus or acute paraneoplastic syndromes. Don't mistake it for typical stiff person spectrum disorder.
Second, the demographics are different. Think older onset, around 58 years median, and a strong male predominance, about 88%.
Third, immunotherapy is crucial, and it works, even for relapses down the line. Don't delay treatment if you suspect this.
And fourth, the most powerful predictors of a poor long-term outcome are the patient's age, and especially whether they require admission to the intensive care unit. That ICU admission carries a very high risk for poor functional status later. So thinking about that last point, given the speed, the severity, and that clear statistical link between older age and ICU admission driving poor outcomes, it really raises a question, doesn't it?
It does.
The study seems to suggest we should be considering whether prompt, maybe even preemptive aggressive immunotherapy should be started even faster in those higher-risk patients, the older ones, those showing early bulbar or respiratory signs perhaps, before they deteriorate to the point of needing intensive care.
That's a critical question for clinical practice.
What steps can we as clinicians take to lower our diagnostic threshold in those specific high-risk scenarios? How do we get comfortable treating based on strong clinical suspicion alone, potentially even before antibody results are back, to try and head off that devastating ICU admission?
That's the challenge, isn't it? Balancing the need for rapid action against diagnostic certainty.
Something for all of us to think about in our own practice. Thank you for joining us for this weekly Neurology Deep Dive. We've been discussing the key findings from the paper by Guasp and colleagues on progressive encephalomyelitis with rigidity and myoclonus, with glycine receptor antibodies.
And just a final reminder, this discussion was for educational purposes only. Please consult the original publication for complete details.
We hope this deep dive was valuable for your clinical practice. We'll see you next time.